You've worked also outside the country. How has that experience been?
So immediately after my internship in 1990, I joined the military medical corps.
Yeah.
Basically to work as a military medical officer, but also it took me away from Kenya to go for the Kenya Battalion 3 for the war in Yugoslavia, the civilian war, 1993-94.
Yeah.
Actually 18 months. But basically looking after the officers and men and their families in the military, that bit I did for 13 years. And then after that, of course I went for my master's in the same university which I did undergraduate when I was still in the army. And then from there I came back and continued as a consultant in Memorial for Armed Forces, or what they call the Kenya Defense Forces Memorial Hostel.
Yeah.
And then later on, I opted, my ambition was to become a professor, and as I said, to pursue academic issues.
Yes.
So I left in 2004 and joined the Aga Khan University Hostel. So essentially I've worked for 2 employers, the military and then the Aga Khan University.
Yeah.
And so when I joined there as a program director to develop and grow the university in the Department of Surgery, I was then taken to Canada for my fellowship after general surgery, which was fellowship in breast surgical oncology and oncoplastics at the University of Alberta, Western Canada. Then I came back, worked for a while, and then I won a scholarship to go and do further studies for further oncoplastics and training in breast surgery in the University of Emory University in Atlanta, Georgia. And then subsequently, medicine is a continuous learning process. So I joined several organizations, but the key one was American Society of Breast Surgeons, where you attend practice-changing sessions and conferences every year. What is new? Because again, cancer treatment is evolving very fast. Every year there's new information coming through, large research data. And luckily, breast cancer has a lot of money for research. And so every year going to America, meeting with colleagues and looking at what is new, what is possible in terms of surgery, in terms of radiation, in terms of chemotherapy, in terms of hormonal therapy, in terms of screening, and what are the tools that are available as we speak.
Wow, great. Now, if I can ask, you started as a general practitioner, and then you went to train as a general surgeon, and then you sub-specialized to look at the breast, and not just the breast, but breast cancer specifically. Why did you decide to take that turn to look at breast cancer specifically?
So when I was doing my master's at the University of Nairobi, what I noticed is that we are dealing with emergencies mainly. Fractures, intestinal obstruction, appendicitis, cholecystitis. So things that are threatening life immediately. But women who came, and it's a common problem, breast cancer is very common worldwide, who came with breast lumps that could be breast cancer, they were neglected as such because they would come and the doctors, the surgeons are busy with the emergencies, so they would delay the clinics. And by the time they come, we are dealing with a very late stage with very poor outcome. And so when I went for one of the conferences in the US, I realized if we have more people specialized in breast treatment specifically, and then bring public health awareness, but also open up breast cancer, dedicated breast cancer clinics, or breast clinics, which has since happened since I went for my training in Aga Khan, Kenyatta. So they're all over the place because we've trained more people. So there are people who are dedicated not just for appendicitis, cholecystitis, but specifically for breast. Because
so at that time there was really a major gap for specialists to look at the breast cancer. All right. Now, if we can now get into the specific of the discussion tonight. Somebody will look at, say, breast cancer, and we've heard about other cancers as well. So if we can start, how will we look at cancer? What is cancer, and what will therefore be termed as a breast cancer?
Okay, so we know that on a daily basis, our cells are programmed to grow, and when they grow old, they die in a programmed way, okay? But at the same time, there are cells that are changing in terms of change on their DNA, change on their genes, and they develop an ability to grow without control. So cancer then, when you're looking at it, the real meaning is cells that are growing abnormally, and then they have the capability to infiltrate to the next tissue or at the joining tissue, and by that, without the normal controls of the body system, they also have the capability of dropping off circulating cancer cells that go through the lymphatics and the blood system, what we call metastasis to the other organs. And actually, that's what kills patients. It's not the cancers per se. It is when it develops that ability to move from the original organ
the
to go to the lungs, which are very life-saving organs, or to the liver, or worse still, to the brain. And that's what kills patients. So that abnormal growth, which is uncontrolled by the normal system, is what we describe as cancer. Yeah.
So in summary, you're saying normal cells usually grow, but they reach a point they die.
We call that process apoptosis.
Apoptosis.
Yep.
It's a controlled,
programmed system of all cells.
Of all cells.
But some might escape that route because their DNA has undergone mutation or changes, what we call changes.
Now, when they undergo those changes, they are not able to die.
Yeah.
They are not able to be controlled in their growth.
No.
And now they become what we call the cancer cells.
And then they could appear now as a growth or a lump.
All right.
Or in blood, they will multiply as many uncontrolled cells, for example, in leukemia or in lymphomas. Yeah.
Wow, great. Yeah. And that is still what happens when we now go specifically to talk about breast cancer.
Same. So the abnormal breast cells becoming uncontrolled and presenting as lumps or changes in the breast. That's what we call breast cancer. Yeah.
Now, when we talk about now breast cancer itself, what causes breast cancer? Because maybe outside there people have myths and misconceptions that, you know, they see a middle-aged woman has a swelling on the breast, maybe it has become even a wound, and they will say something like, that woman was bewitched or something close to that. So what causes these breast cancers?
So even as an expert who has been in this practice for over 30 years, my take is that it's very difficult for the majority of breast cancer to pinpoint the actual cause. In other words, the causes of breast cancer are mainly multifactorial, but there are some risk factors that make somebody develop breast cancer. So just for the record, is that also men have breasts, but our breasts are not developed as the women's breasts. They're actually, like they are there, but they don't have the glandular tissue that produces milk.
Yes.
Okay. So they have mainly just small amount of, and it's because we don't have as much estrogen. We don't have ovaries, so we don't produce estrogen and progesterone that women produce that helps them to develop the proper breast for breastfeeding. So the highest risk factor is being a woman. So the gender, the gender female are more predisposed to breast cancer because of their hormonal, the hormone estrogen progesterone balance. Okay, because one is for growing it, another one is for developing it, another one is for making sure that the milk production is done. And those changes, if a woman, for example, is exposed a lot, like if she starts her menarche early, if she gets her first periods early, like less than 12 years, and those changes come monthly as they have their periods for a longer time, so that also her menopause is late 55 years or over 50 years. That exposure and challenges to the breast cells is what makes women more predisposed to breast cancer. The other, of course, is if you delay to breastfeed the child. In other words, if you get your first pregnancy after 30 years, it will still means that you have been exposed to a longer period of fluctuating hormones. And also, if you are born in a family, or if there's genetic mutation, that's only about 5 to 10%. So there are women who have their cancer, there are genes that protect them from cancer. They're called breast cancer genes 1 and 2. Of course, the others, like TP53 and CHEK gene, but the main ones are breast cancer genes, the BRCA1 and BRCA2. If they have changed, or they have been mutated, as it were, in your family or in your relatives, you are likely to develop breast cancer compared to the normal population.
So if I'm a lady and my mom or my grandmother or my aunties had breast cancer.
Yes, particularly before menopause.
Before menopause.
Before they reach their menopause.
Okay.
That means that most likely they have mutations of the breast cancer genes.
All right.
So the likelihood of developing breast cancer is almost 95%, and ovarian cancer. Particularly if the BRCA gene 1, you know this breast cancer gene 1 and breast cancer gene 2.
Sure.
If they have been mutated, the likelihood that you will develop breast and or ovarian cancer is very high, particularly if they got the cancer before they reached menopause.
Okay, thank you. I think we hold the discussion there. We are going to take a break, and when we are back, we'll continue talking about who is at risk of developing breast cancer. So stay tuned.
I'm a Halloween ghost.
The news that matters the most is the one that hits close to home. When disasters strike, we are there to inform you. When the bullets are flying, we tell you who's shooting and why. Reporting on your victories, your health, your money, your security, your past, present, and future. We are interested in telling the stories of creativity, hard work, and resilience that you are known for.
That is our job. This is my job. My name is Victor Muyakane, and it's my honor to bring you this news this way every Thursday night on the home of Untold Stories.
Katika majengo haya, hapa ndipo sheria zinapotungwa na zinapopakuliwa. Nitakuletea viongozi mbalimbali, mirengo mbalimbali, wote kwa pamoja wakipika na kupakua. Tutawapa nafasi kuweza kuangazia changamoto na mafanikio ya ugatuzi katika ukumbi wa siasa kila siku ya Jumanne kuanzia saa 1 kamili na kuendelea.
Toka eneo hili la Naivasha kwenye kaunti 032, gatuzi la Nakuru.
Toka kaunti ya Elgeyo Marakwet, kaunti 028.
Nikiripotia runinga ya TV47 kutoka kaunti ya Wajir.
Nikiripotia TV47 kutoka kaunti ya Turukana.
Kwa matukio yote yanayojiri katika kaunti hii 012.
Kutoka kaunti nambari 1, kaunti ya Mombasa.
Nikiripotia TV47 kutoka kaunti ya Lamu.
Nikiripotia TV47 kutoka Kisii County.
Nikiripotia TV47 kutoka kaunti ya Machakos.
Kutoka kaunti hii ya Trans Nzoia.
Kaunti 038.
Kutoka gatuzi nambari 029, kaunti ya Nandi, chemichemi ya mabingwa.
Nikiripotia TV47 kutoka kaunti ya Kakamega.
Nitakuwa nikiripotia runinga ya TV47 kutoka kaunti ya Bungoma.
Jina langu ni Paula Munio.
Willy Dennis Jiru.
Fabian Kibet.
Mimi ni Hashim Jimal.
Mimi ni Kitio Mika Masai.
John Javakiania.
Jina langu ni Abdulaziz Nameka.
Mimi ni Kombo Alfayo.
Jina langu ni Nicholas Mbai.
Isaac Famba.
Mimi ni Wanji Sosti.
Jina langu ni Arnold Adidi.
Jina langu ni Chris Bet.
Jina langu ni Violet Auma.
Na TV47 inapotamba, mimi Sheila Chelangat nitakuwa nikiripotia maswala yanayokuhusu wewe kila kuchao.
The other lifestyle things that are attributable to development of breast cancer, one of them is postmenopausal obesity. So women who have challenges with weight after menopause, you know that menopause means the ovaries function has reduced dramatically. But now the body has the capability of converting, or the fat is not as inactive as you think. It has a capability of converting any other hormones to estrogen, particularly androgens that women have from the adrenal glands. It can be converted to estrogen, and therefore that puts you at a higher risk. So lack of exercise that leads to obesity may also lead to breast cancer in postmenopausal women.
So even if the ovaries have kind of shut down,
yes,
there is still other estrogens that are being produced
from the fat. Because you're obese, you have fat.
Right.
And the fat is utilizing the androgens that you produce from the adrenal glands and other organs.
All right. So if I can, if I can cut the conversation now, there are other misconceptions. Is it misconception really, or but if you can clarify to us about use of contraceptives? Do contraceptives put women at risk for breast cancer?
Yes and no. So clients or people, women who utilize low estrogen doses of family planning, for example, specifically FemPlan or microgynon, which has a low dose estrogen, they don't seem to be at a high risk. But women who utilize mixed contraceptives, for example, the ones that contain both estrogen and progesterone, or progesterone and estrogen, they have a tendency to have to double their chance of developing breast cancer. But specifically those who use high progesterone depot, like Norplant, the Depo-Provera, those emergence pills, they're all progesterone based.
Yes.
And then Mirena, for people who are bleeding, they're given as an ICD. They have a higher chance of developing breast cancer. And the reason is because the progesterone is broken down into two components, what you call Brachionon 1 and Brachionon 4 and 5. And this, they put the breast in an inflammatory status. And that inflammatory proliferative status makes the breast cells very unstable. And therefore, the development of breast cancer becomes a bigger chance when you're utilizing those contraceptives. Studies have been done and shown that those progesterone-based contraceptives used for a longer time are higher risk. And also these emergency pills are used for post-coital emergencies. They have been shown to cause breast. In fact, I think for the younger patients, like last week I saw a 28-year-old and a 21-year-old. There was no family history, but she had in college used a lot of those emergency pills, and I could pinpoint that. Like when the breasts are still very young and they haven't breastfed. Also, so when the breasts develop in a lady to a particular point and are waiting to be breastfed, they are in a very unstable and inflammatory state until one has a term pregnancy. That's why getting your pregnancy earlier protects you, because it moves anatomically the cells from lobule, the lobules that produce milk, it moves them from unstable lobule 1 and 2 to lobule 3 and 4, which are stable after pregnancy and breastfeeding. So pregnancy and breastfeeding actually protects you from breast cancer.
Those are the changes that happen in the background. We can't.
Which most people are not aware, but it does happen at microscopic level.
So pregnancy, like having an actual pregnancy, plays such a crucial role.
Absolutely.
We might just say it as a cliche, but it's something that is important.
So when you get pregnant term and then you breastfeed, it protects you against breast cancer 40% of the time.
40%?
It's very high.
That's quite a significant number.
So the other things that would cause breast cancer is drinking alcohol, particularly if you take more than one drink per day. Yes.
Alcohol.
Now,
somebody will argue, how is alcohol leaving the digestive system to the breast?
No, it's the metabolites that are metabolized in the liver, as you know them, Daktari. So the aldehydes also reach the breast tissue. They have receptors, and they put them in inflammatory status.
So after after the alcohol is broken down in the body, the products circulate in blood,
and they have receptors in the breast cells. So excess intake of alcohol regularly puts a woman at a higher risk. And what is excess? More than one drink. And what is one drink? More than a glass of wine, or one bottle of beer, or 2 tots of whiskey. So that's basically it. But unfortunately, most of the young people nowadays, if you go to a party, you find that they have gin and bottles of liters of there as they wait for the meat to come.
Yeah.
And their men are paying for it, but they're also paying for breast cancer in the process.
Wow.
Also, smoking has been shown, excessive smoking.
Yeah, I was about to ask you about that, the same.
Yeah, so lack of exercise, which leads to obesity,
yes,
is the same thing. And vitamin D deficiency.
Yes.
Yeah, doing a study on vitamin D deficiency as it relates to breast cancer, of course, not only breast cancer, but prostate, kidney, and others. It showed that women who are deficient in vitamin D levels, which we get from sunshine mainly, and unfortunately we are always in the offices, so we don't get it, has been associated with development of. So those are some of the risk factors that I can be able to.
Wow, that's quite eye-opening. I trust the viewers is getting to know some of these things that we take for granted. Now, I understand there are many other risk factors, but for the interest of time, let's move on. Now, let's assume somebody has this risk factor and there's a breast cancer that is developing. What are the early signs or symptoms that somebody can pick up at home to be able to suspect that there is something unusual happening with my breasts?
So breast cancer, the usual presentation would be a painless breast lump.
Painless.
Painless. And that's why people go late, because they are praying that this thing will disappear, right? Unfortunately, it doesn't. So, and that's why in the process, then they go late, because what takes most people to hospital is pain. If you have a painful tooth or a broken leg or your tummy is swollen and it's not passing stuff and it's painful, you rush the hospital. But if you have a painless something, you're likely to pray about it and wait or ask or ask other people, what does it mean?
Yes.
And just so that people are clear, there are lumps in the breasts. Fortunately, 90% of the time of those lumps are not cancerous. It's
90%.
only 90%. You know, any woman in her lifetime will have a lump, which could be a lump, a real lump, solid, or a cyst. 90% of the time it will not be cancerous. But now you can't differentiate what is cancerous and what is not cancerous. The only way is to go to the hospital.
Yes.
The other way that breast cancer will present is bloody nipple discharge, particularly if it is spontaneous and it's on one side, not when you squeeze, and it's not on both sides. So if it's bloody, spontaneous, and one-sided, that should worry you, and that should be attended to. Again, most of the bloody nipple discharges are caused by papillomas, which are benign. They're not cancerous, they're not malignant, but the only way you can know is by going to the doctor.
Yes.
And then you might find there's thickness or change in the nipple size or a position, there's a retraction. You might also find that there's a particular type of cancer which is called inflammatory breast cancer. The whole breast is inflamed, it is hot, it's, and it's very difficult. And then...
Can it be like one breast is larger than the
other? And it has changed in shape.
In shape, okay.
Yeah. You might find that that's what you have. And additionally, someone might just present without a lump in the breast, but they have a lump in the armpit, in the axilla.
In the armpit areas.
So the notes are showing they have issues, but the breast, it is hidden. So you have to do some other studies to establish. But what is important, all these symptoms and signs of breast cancer might be picked up if you go for screening, because screening can pick these issues that are changing to cause cancer 2 years before the patient can feel it or the doctor can palpate it. So that's why
you're feeling it. It's already like almost 2 years.
2 years since it happened, and so that's why screening becomes very important. In fact, the take-home message about it is that what has changed the outcomes of breast cancer is early screening, and then the changes in the systemic treatment, what we call the chemotherapy and hormonal therapy. That's why the outcomes are very good. So people should be encouraged to go for screening, particularly after 40 years. They should go for mammograms.
Let's talk about the screening part in more details.
Yes, so I think that screening has not been taught by our people. And I also blame it on ourselves as me and you as doctors. I don't think we have on the community health people and the government, because we haven't sensitized. You know, like now it's breast cancer month, is when we are talking about it. But it should not be October, we should not be waiting for October. We should be sensitizing the patients and the community and the public continuously. Actually, in developed countries like where I did my studies in Canada, people are called on their birthdays to go for screening, whether it's colon, prostate, or breasts, because those are common cancers.
Yeah.
So I think that we should use a method that is a continuous process throughout the year.
Yes.
And for patients for people, not patients, who are more than 40 years, the best screening tool is a mammogram. Luckily enough, the government, the Kenya government from 2020, after they established the National Strategy for Cancer, they also took action and sent a lot of, in different counties, a lot of mammograms and ultrasounds. So there's capability. Of course, the challenge is the human resource, the people who know how to do those things. But screening for 40 and above, every year until you are 55 with mammogram annually. And then for patients who are at high risk, for example, those who have genetic mutations and all that, who are less than 40, they should be done MRIs, yearly MRI, because mammogram won't help.
We can hold the discussion right there. We are going to take a break, and when we are back, we continue right with the discussion about screening. Stay tuned.